send it to everybody. At least my present.
That's nice, yes.
Perfect time. Please.
Thank you.
So I'll let you introduce me first. I think so. Let me.
Good evening, everybody. I think we have to start so you can have time after the last session this evening, and then you can go for dinner early. Otherwise, we'll stay here forever. Okay, great. Good evening, everyone, and thank you for being here today. And it's a great honor to be with you this evening. I know everyone is tired now, and everyone is keen to go quickly home or just have his dinner. I think the session just maybe there is no single meeting without talking about diabetic macular edema, especially in this area of the world, where we have nearly endemic of diabetics, and we have all the problem of diabetes and all the variety of the pathology and scenarios that we can see in this area of the world. Diabetic macular edema is one of the more challenges, which is definitely the leading factor for loss of vision and diabetic retinopathy cases, and we have many options for treatment for our patients at the moment. I'm going to introduce my colleague, Dr. Fahd Kohel, who is the speaker for this evening. And actually, I know Fahd from England. We worked together for a while, and he's a big fan of using steroids as well in diabetic macular edema. So he will address the issues or the gaps that we're still having in treatment and managing of this patient. And I don't want to introduce him anymore. He is a consultant in Moorfield, Abu Dhabi, just moved recently from United Kingdom. Before this was a consultant in Sheffield, am I right?
Yes.
Yes, great, exactly. And we'll listen from Fahd what is new in the diabetic macular edema management, okay?
Thank you. Thank you, Ibrahim, for the introduction. Sorry, guys, if I can just ask everybody just to lower their voices, please. If you don't mind. If you want to talk, by all means do, but leave the hall and talk outside. Otherwise, can I have quiet and silence? If you don't mind, I do apologize. Can I have my slides, please? Can someone put my slides on, please? AV guys, hi. Can you put my slides on, please? So just as Ibrahim very kindly said, I'm actually from the United Kingdom, and I've been attending Meom for the last 3 to 4 years, and I've been a kind of an active contributor. But this year, I decided to actually move to the United Arab Emirates. So alhamdulillah, I've managed to get a position at Moorfields Eye Hospital here in Dubai. And I'm really enjoying the new environment and working here in the United Arab Emirates. So apologies, we're just going to wait for our slides to start. Excuse me, I'm just going to go to the AV guys. Do you have the presentation ready, or do you want it? I have it on my USB stick. The clicker's not moving forward. Here we are. So, we'll get into the talk, but I just wanted to share this picture. This is where I used to live in the UK, in an area called Sheffield. It was very close to the Peak District. Absolute beauty spot. I do miss home, but I'm very happy to be in a new environment and be here in the UAE. These are my disclosures. So it's quite clear that macular edema is mainly inflammatory driven, be it uveitis, be it diabetes, be it retinal vein occlusion, and inflammatory mechanisms play an important role. It's important, although we always think of macular edema as VEGF mediated, we forget that there are other inflammatory mediators that are upregulated, like IL-6, like MCP1, that also contribute to the breakdown of the blood-retinal barrier and contribute to your macular edema, be whatever cause, be it AMD, vein occlusion, uveitis, or vein occlusion. And it's really important to recognize the role of inflammation in diabetic macular edema, and that there are subtypes of diabetic macular edema that although VEGF is a very good drug, you will not get an optimum treatment response, either in terms of vision or in terms of anatomy, and that's because the inflammatory pathway is the major driver for the breakdown of that blood-retinal barrier, and it's important to recognize that subgroup of patients where anti-VEGF isn't beneficial and making the switch to an alternative approach to give that patient the gain in vision, that improvement in quality of life. And this slide kind of just illustrates the point that you get leukostasis, upregulation of ICAM, as well as VEGF, leading to breakdown of the vascular permeability. So when you're treating diabetic macular edema, yes, it's very important to suppress the VEGF component with anti-VEGF treatment, but it's recognizing there are other mediators, and that there are some patients where suppressing the VEGF alone is insufficient. You're not going to improve the vision, you're not going to restore the anatomy, and actually you need to be considering something like a corticosteroid because of its broad spectrum of action and the fact that it suppresses a number of mediators as well, and including VEGF. And this just kind of highlights the same point, so we'll skip the slide. And again, this highlights the same point that, don't forget corticosteroid does suppress VEGF activity. But I'd like to bring everyone's attention to this particular study, which was published just a couple of years ago called the Imagine DME study. So there's a study in the United States where they looked at treating diabetic macular edema with anti-VEGF and seeing if you give additional panretinal laser, whether that reduced the burden of injection. But there were a subgroup of patients where they actually took samples from the aqueous humor and measured the cytokine profile and matched that cytokine profile to how well their macular edema responded to anti-VEGF. So you had your super responders, your partial responders, as well as your non-responders. And what was fascinating is that the super responders had a high VEGF component within their aqueous cytokine expression, whilst the non-responders didn't have as much VEGF expression and had other mediators like MCP1, like IL-6 that were expressed. So the real world tells us there is a component, there is a group of diabetic macular edema patients where VEGF alone, VEGF suppression alone, is inadequate to meet that patient's vision needs. But now we have basic science to support it's because the VEGF is not the major mediator for the breakdown of the blood-retinal barrier. So we need to consider a drug with a broad spectrum of action for those cases where VEGF isn't meeting the needs for that patient. And the EURETINA guidelines recommend, considering corticosteroid in any anti-VEGF that doesn't respond from 3 injections, after 3 months, for pseudophakic patients, patient with a history of a cardiovascular event, or patients who have great difficulty maintaining the 2 monthly visits that are required for the optimum vision outcome with anti-VEGF treatment. Very, very quickly, this was a case control study, a worldwide one, where they had 2 arms. The top arm, or the dashed arm, both arms had anti-VEGF for the first 3 monthly doses. But where the distinction happened is that in one arm, and both arms had insufficient response to anti-VEGF, which was defined as either less than a 5-letter gain in vision or less than a 20% reduction in central retinal thickness. But the difference between the 2 arms is at 3 months, they either were given an Ozurdex injection or they continued with anti-VEGF monotherapy. And those patients with an insufficient response to anti-VEGF after 3 injections, if you continued their anti-VEGF, you did not get any additional gain in vision. You were not making any difference to that patient. But if you switched them to steroid, you got a 5 to 6 letter gain in vision. And that's how I recognize those patients where steroid will make the greatest benefit. I give them that 3 to 4 loading doses. If I'm not seeing at least a 20% reduction in central retinal thickness, or at least a 5-letter gain in vision, then I'm thinking, do I need to switch to an alternative to treatment? And corticosteroid, because the macular edema is inflammatory mediated, and continuing with VEGF is not in the patient's best interest. This was a guideline that was devised in North England a year or 2 ago, and that was to try and standardize the introduction of intravitreal steroid in patients who had a suboptimal response to first-line anti-VEGF or ongoing